name is Giovanni Ceccarini. I'm from the University of Pisa, where I'm associate professor of endocrinology. I work here at the Obesity and Lipodystrophy Center. Approximately 10 years ago, we started being interested in lipodystrophy and start following patients, and we have developed a center which is now a referral center for Italian patients. As you can see here, I'm sure that you see my first slide. Our center is part of the Endo-ERN, is part of the Meta-ERN, and is part also of the European Consortium on Lipodystrophies. I'm coordinator of the sub-team or subgroup lipodystrophy inside the main thematic group 3, genetic disorders and glucose and insulin homeostasis. I've entitled my talk today, Understanding Lipodystrophy. I will give a broad overview on the disease. I hope that I will receive many questions, and my talk will be followed by the talk of a patient, Dr. Rebecca Sanders, who is also the representative for the UK Patient Association and the representative of patients inside the European Consortium of Lipodystrophy and ECLIP registry. So I think we are basically ready to start. Maybe just one more minute before presenting the first slide, which is the definition of the disease. There is no doubt that lipodystrophy is a medical term which is frequently misused or used under different conditions. So I will start defining what we mean with lipodystrophy, with the word lipodystrophy, and discussing with you the basic characteristics of the disease, how we can make diagnosis, the prognosis, and the possible treatments that are available today. So first of all, my conflict of interest. I've been consulting for the company which produces the recombinant form of the hormone leptin. And here, as I said earlier, I'm presenting the definition of lipodystrophy. We refer to lipodystrophy indicating a condition which is based on lipoatrophy. So the disappearance, the unintentional disappearance of fat. Fat loss is present in the absence of nutritional deprivation or catabolism. Lipoatrophy or lipodystrophy is associated with metabolic syndrome, and we will see in the next slide why. Lipodystrophy is not one disease, but is a word which defines 40 different forms of lipodystrophy. Some of them are very, very extremely rare, some others more frequent, but all of them are very heterogeneous and different one from the other. Approximately, we can estimate that in Europe we have at least 1,200 patients, but probably more, because this prevalence estimate is probably underestimated. So what exactly, what are the basic principles of the mechanisms that are responsible for the disease and its complication? I will start describing this aspect using an animal model, a transgenic model, which is characterized by the expression in the white adipocyte of a caspase. So activating this caspase, you can you can induce apoptosis only in fat adipocytes. And you can see clearly here that adipocytes are gone after the activation of the caspase. So the animal starts losing weight. You can see clearly here. It's losing weight because it's losing adipose tissue, which is apparently a good thing, something that we would all like to see in our obese patients, for example. But this is not good, because when you lose adipocytes, you also decrease the circulating leptin levels. Leptin is an important regulator of food homeostasis and appetite. So when leptin levels drop down, the patient, or in this case the mouse, increases its appetite. And since the appetite is increased, what we call hyperphagia, and there is no place where we can put the extra calories in the body because we don't have fat tissue, now the fat starts accumulating ectopically in other organs. For example, in liver, generating fatty liver and fatty liver disease, increasing the triglycerides in the blood because there is no other place where they can obviously can be stored. And this condition generates insulin resistance and is followed usually by the development of type 2 diabetes with extreme insulin resistance. So these are the principles that are associated with the disease and the metabolic syndrome which is associated. We are frequently asked, how can you make the diagnosis of lipodystrophy? Well, first of all, you have to demonstrate that subcutaneous fat is gone locally or in generalized in the body. So here you can see two examples of patients with different forms of lipodystrophy. And lipoatrophy is associated with other supportive clinical characteristics. So these aspects may be important for the suspicion of lipodystrophy. For example, the presence of type 2 diabetes or extreme insulin resistance, the presence of hypertriglyceridemia, or the history of a previous pancreatitis, for example, in a young patient, evidence of hepatic steatosis or severe steatohepatitis, prominent muscularity or splenomegaly, because obviously the subcutaneous fat is gone, is reduced. Family history of similar physical appearance, and finally, disproportionate hyperphagia. So a patient may tell that he's frequently thinking about food, cannot stop eating, and so on. Here are a few examples coming from, some pictures are coming from our cohort of patients. You can see here acanthosis from a 14-year-old patient with a congenital form of lipodystrophy. You can see here serum, lipemic serum from a patient that has severe hypertriglyceridemia or xanthomata. You can see the enlarged abdomen of a young boy, and this enlarged abdomen is due to hepatomegaly, a severe hepatomegaly, which is frequently found in congenital forms of lipodystrophy, together with this umbilical hernia. This is another sign of lipodystrophy, the prominent muscularity, an appearance which looks like very fit, but is due to the decreased amount of subcutaneous fat. And obviously the veins, splenomegaly, the veins are more evident in these patients. Other aspects that may be associated and important to be recognized because they may be associated with syndromic lipodystrophies are the acromegaloid phase, typical of congenital forms of lipodystrophy, the progeroid phase, signs of premature aging. Many forms of lipodystrophies are associated with progerias. Cushingoid phase. So in this case, there is an increase of fat in the face or in the neck. This may be also a sign important to be recognized, or the classic lipoatrophic phase that you can see here at the bottom in this curve. As I said earlier, patient may refer increased appetite, and it is clear that on average, a lipodystrophic patient eats at least 30% more calories than the predicted. And this is because, as I said earlier, the reduction or the disappearance of the fat mass, the white adipocytes, decreases circulating leptin levels. Leptin is an important anorectic hormone, and if leptin levels are down, hyperphagia develops. But if hyperphagia starts and we do not have the organ where to put the extra calories and the triglycerides, it's clear that these triglycerides will be hosted somewhere else, topically, for example, in muscle, in pancreas, heart, liver, generating a metabolic syndrome, which is sustained by the this ectopic accumulation of triglycerides and leptin resistance. Some patients have a physical appearance of polycystic ovary syndrome, and maybe the disease may be confused and wronged with PCOS. In this slide, you can see a summary of the most frequent comorbidities that are associated with the different forms of lipodystrophy. Some of them were already mentioned, others not. For example, in lipodystrophies and in some types of lipodystrophy is not rare the presence of a cardiomyopathy or arrhythmias. It's very important the reproductive aspect, because leptin, as you know, is an important modulator and regulator of GnRH neurons. So usually when leptin levels are very low, central hypogonadism may develop, and some of these patients may have and display infertility. Kidney disease is not rare at all. And finally, other important aspects not well understood yet: chronic pain, which is frequently referred by our patients, and mood disturbances. This is a recent paper by Akinci and collaborators showing the characteristics of 230 patients affected by lipodystrophy. As you can see from this long table, 90% of the patients at time of the diagnosis had at least one elevated lab value, either triglycerides, glycosylated hemoglobin, or transaminases. And at diagnosis, 80% of them had at least one organ abnormality. So this clearly tells that at time of diagnosis, some kind of comorbidity has already developed and is progressing. I would like to stress the important aspect of the mood disorders, sense of well-being, chronic pain, as I said earlier, which is frequently reported. This is our casuistic, what has been detected in the cohort of the patient that we are following in PISA. You see that 80% of them has chronic pain and had to take painkillers, some drugs, even very, very potent drugs. And you can see here at the bottom that 70% of them, in theory, may be classified, wrongly classified, I should say, as having an eating disorder. This is not a pure eating disorder. It's just a disorder which is driven by the reduced leptin levels, obviously. Lipodystrophies are classified in 4 large groups or families, based on, first, if are genetically determined, so congenital or familiar in one case, or acquired, and based on the distribution of fat loss, generalized or partial. So as you can see here, you have 4 different groups that are the major categories that we use to subdivide the different disorders. Now, the diagnostic flowchart for lipodystrophy can be extremely difficult, complex, and requires, no doubt, experts that are working on this field. I would like just to please keep in mind that when you see a patient, always ask yourself how diffuse is the fat loss, or is either a generalized form or is a partial form? Are present aging traits indicating that this is a lipodystrophy associated with progeria syndromes? Ask yourself if the patient is taking medication that are possibly causing lipodystrophy. This is very frequent in HIV-infected patients because antiretroviral therapy can cause a secondary lipodystrophy. And ask yourself when lipodystrophy started developing. So in the first months or years or later on. likely an acquired forms, therefore. I would like to show some pictures of our patients, starting from one of the most common forms of lipodystrophy, a classical one, congenital generalized lipodystrophy type 1, Berardinelli-Sape type 1, is caused by a mutation in a gene which is making triglycerides in white adipocytes. The disease is recessive and is causing a generalized form of lipodystrophy. As you can see here, a young boy which you can barely tell that is affected by lipodystrophy. You can say these skinny legs probably, and he has no complications. But if you leave the disease untreated and unrecognized early on, all the complications that you may predict and expect develop: insulin resistance, hepatomegaly, and then hypertriglyceridemia, diabetes, and later on the patient will have even complications from type 2 diabetes, as was the case of this 50-year-old patient that was followed at our center and developed a severe retinopathy and kidney insufficiency, kidney failure. The second disease that I would like to show and discuss with you is the familiar partial lipodystrophy type 2. This is also known as Dunningham syndrome. It's a lipodystrophy which is caused by lamin A gene mutations, and the disease is dominant. So this is not a very rare disease. It's one of the most frequent forms of lipodystrophy which you may encounter in your clinical practice and clinical activity. We don't have time to go, obviously, in depth and in detail describing or talking about all the possible genes that are causing lipodystrophies, many of them. We can just say here that the genes causing lipodystrophy are either involved in triglyceride synthesis, as we said before, in lipid droplet formation, or in the maturation of fat tissue, for example, PPR gamma mutations. Some of these mutations are recessive, other dominant, and the disease in the suspicion of a genetic form can either detected by direct sequencing of a candidate gene, or using gene panels, or even whole exon sequencing. All these activities obviously can be performed in referral centers that work on lipodystrophy. This is just to remind that acquired forms of lipodystrophy are likely mediated by an autoimmune aggression against the fat. We don't know yet the markers. We don't know much about the possible antigens. In this suspicion, always try to explore the possibility that the patient, if the patient is already affected by other autoimmune disorders, as you can see listed here, and can associate with lipodystrophy. Acquired generalized lipodystrophy is also known with the name of the first physician who described the disease, Lawrence, Dr. Lawrence. Lawrence disease is more frequent in females. Can be the onset of the disease can be with the panniculitis, and the fat loss is generalized, but preserving retroorbital and bone marrow fat. On average, at around 15, 16 years of age, patient develop type 2 diabetes. And the only antigenic marker that we have discovered so far is the presence of the antibodies against the perilipin 1, which is expressed in white adipocytes. So this patient have circulating antibodies against this antigen perilipin 1. Sometimes, as I was saying, in 1/3 of the cases, the disease starts with the panniculitis, a bump, sort of hemorrhage under in the subcutaneous area, which is followed by, you see here, fibrosis and clear area of lipoatrophy, which can extend and progress over time. The progression can be in weeks or in months or in years. Another not rare form of acquired lipodystrophy is the partial acquired lipodystrophy, also known and indicated as Barraquer-Simon syndrome. The typical feature of this lipodystrophy, as you can see clearly from this picture, is that fat loss occurs only in the upper part of the body. So in the face, especially in the face, in the neck, and in the arms, while the fat in the legs is preserved. Again, probably this form is mediated by some kind of autoimmune disorders. In fact, at least 70% of patients display reduced circulating C3 levels and have circulating levels of an antibody which is called nephritic factor, which can be associated with glomerulonephritis. We know that there is a genetic predisposition because some HLAs are more frequently present in these patients. So what kind of systems can we use to help us in the diagnosis? As I said earlier, the diagnosis is mostly clinical, but we always use systems that can help in estimating the amount of fat tissue in the body, starting from using the classic glycometry, using very often in all of our patients DEXA scans, in some specific cases, magnetic resonance to understand where exactly adipose depot are present. And finally, very recently, David Araujo Virar has developed a phone application called Lipodystrophy, which you can download on your mobile phone and has a sort of internal flowchart, which may help those that are less familiar with the disease in guiding them to a possible diagnosis of lipodystrophy. What about leptin levels? There is no doubt that in all patients, by definition, leptin levels are reduced, but unfortunately, leptin levels are not that useful in the diagnosis. No doubt that in generalized forms, leptin levels are very low, extremely low, but unfortunately, in partial forms, they may overlap with normal circulating leptin levels, therefore leaving room to doubt. I'm using this slide just to stress one point. You may have seen that most of the lipodystrophic patients, the predominance, probably 70%, are female. So why is that? This is because fundamentally for two reasons. First reason is that acquired forms, which are autoimmune, are more frequent in women. The second reason is that subcutaneous fat in women is more present, is more physically abundant. So the lack of this organ has more metabolic impact in females rather than in men. And this brings usually patients to the attention of the physician. Now, the history of our patients is very complex. Some of them reach a diagnosis, the correct diagnosis, after decades. They have been searching and looking and wandering in physicians' ambulatory. This is well described by an article published in the New York Times not too long ago by Gina Colata. It's a very interesting story, which is clearly reflected by many data accumulating in the medical literature. On average, and these are data again by Baris Akinci, the age at diagnosis in patients mostly with congenital forms is at 12 years. And on average, This type of patients may reach for the first time a treatment center when they are 16 years of age. This is clearly too late because at this point, some organ damage may be already present and are to revert. Generally speaking, there is clinical evidence that generalized forms of lipodystrophy reduce the life expectancy. This is less evident in partial forms. And to try to contrast the development of comorbidities, it was clear that the best option we had was to give back the hormone that was lacking. In other words, treating patients with metreleptin. Metreleptin is now a hormone drug available in the market in the United States, in Japan, and is now approved by the European Agency for the treatment of lipodystrophic patients in Europe. We do not have much time to discuss the details of the treatment, but I think it's important to stress that with metreleptin, we can very well control high triglycerides level, we can improve glycosylated hemoglobin, we can protect the kidney, we can reduce, we can definitely improve insulin sensitivity and reduce appetite. This is also accompanied by usually an improved sense of well-being and also the reduction of this chronic pain, which is frequently reported by our patients. So we do not have large sets of data, but there is some emerging evidence indicating that the precocious treatment with metreleptin in lipodystrophic patients, especially in congenital generalized forms, can clearly reduce the mortality risk by 80% or so. Obviously, a limitation of these studies is that the cohorts of patients are always quite small in size because this disease is so rare that putting together relevant numbers of patients to conduct any type of study, especially studies exploring the potential of therapeutic agents, is very difficult. So for this reason, some years ago, we started a new challenge, a new adventure, trying to put together all the European and not only European centers which are working on lipodystrophy. ECLIP has now a registry, the European Consortium of Lipodystrophy has now a registry, the only registry present in Europe, which includes centers that are also outside Europe, for example, centers from Turkey and Russia. And we have been able to introduce in the registry approximately data from 450 patients, and the registry is continuously growing. So we believe that this resource will be invaluable for giving new answers to our patients. And this ECLIP registry will be obviously in the future connected to the all registries that will be related to the Endo-ERN activities. So why did I entitle Understanding Lipodystrophy? Because I think that from my talk, it will be clear that there are so many questions that need to be answered, starting from the precise boundaries of disease and how to make the proper diagnosis, and better understanding mechanism of disease and novel diagnostic tools, possibly. Developing specific treatments, novel treatments. There is something going on under this perspective. And obviously better understanding patients' needs. Patients who are becoming part of our activities, as we will discuss later with Rebecca. My final slide, I don't have to say much about the slide, is why I think a sort of decalogue, why I think it is important to diagnose lipodystrophy. I think I can leave it as it is without saying more, because I don't want to reduce the time for questions or the open discussion with all of you. As I said, by definition, partial lipodystrophy is characterized by inappropriately low leptin levels. There is some room of efficacy of metreleptin treatment in patients affected by partial lipodystrophy. We are following some of them here, or in all over the world. Patients have been treated with leptin. Usually, the efficacy is reduced compared to the response of patients with generalized forms, but there is no doubt that many patients can take advantage of the treatment. Right now in Europe, the treatment is allowed for patients with partial lipodystrophy who, under classic anti-diabetic or hypolipemic agents, do not control very well the comorbidities. So in this case, the treatment is allowed, but depending on the national health system, it may be reimbursed or not reimbursed. So there may be some, let's say, practical issues in order to get the drug for treating the patients. Pietro is asking, what about the kidney involvement? Well, one possibility typical for congenital generalized forms is that this is a secondary disease to type 2 diabetes. Second, it is increased the prevalence of membranoproliferative kidney disorders in Barrett-Simon, and in this case, probably there is this is related to the development of autoantibodies against the tubule. Third, in forms of progerias, it looks like the kidney is aging so rapidly that these patients develop a kidney failure, which is due to a precocious aging, I would say. So the mechanisms are very different based on the type or subtype of lipodystrophy. Another question is from Trina. He's asking what if we know if there is an association between lipodystrophy and high white blood cells. I'm not aware of this association, with the exception of extremely rare types of lipodystrophy, which are associated with sort of lymphoproliferative disease, which is causing an autoimmune form of lipodystrophy. So especially if we are talking about very high levels of white cells, something like 20, 30,000, this may be possible. If it's just a mild elevation, this could be secondary to infections, because lipodystrophic patients, I didn't mention, since they have reduced leptin levels, and leptin is a modulator of the immune system, they are more prone to infections. Besides the fact that they are also diabetic and so on. But so another possibility is that the levels are high because of a chronic infection, which is sort of subclinical or silent. Fiorella, okay. Yes. What about clinical trials with adiponectin or other? Okay. Fiorella is saying, what about giving back adiponectin as well? This is a very good question. In animal models of lipodystrophy, giving back leptin together with adiponectin did better than either one alone. So I think that the future will give will be to give back as much as we can coming from fat, just to resemble what happens obviously in vivo in our body. But as far as I can tell, in humans, no trial like this has been attempted so far. Obviously, the alternative would be to do a transplant of fat, a fat transplant, which is supposed to work here. Could fibromyalgia be confused with familiar lipodystrophy? I've been diagnosed with both. I think so. I think so. The chronic pain is not very far from fibromyalgia. I'm not an expert in the diagnosis of fibromyalgia, but there is no doubt that the condition can be confused. Yes. So it's important that a patient is followed by an expert of lipodystrophy to rule out the disease, and also a very good rheumatologist in order to make sure that the fibromyalgia clinical requirements are fulfilled. Maria has a boy who is 14 years old. He's a patient affected by Berardinelli SAPE. He doesn't have yet insulin resistance at the moment, but he has started with steatosis in his liver. Do you recommend the treatment with leptin? Yes, very, very good question. They are worried about lymphoma risk. First, I think it's important to start as early as you can, because otherwise other complications may develop. We had a very similar experience to yours. We started the treatment and the patient improved dramatically. The liver size, the liver reduced, and the liver steatosis was behaved very well, responded very well to the treatment. So yes. Lymphoma risk, I don't think this is the case, because if there is a risk of lymphoma, this is typical of acquired forms of lipodystrophy. Patients with generalized acquired lipodystrophy have an increased risk of lymphoma, but this is typical to all complex autoimmune disorders. So it's not related to leptin treatment itself, although there is a warning box in the drug, as you may aware, because you made a specific diagnosis. So I would not worry at all about the lymphoma risk in this specific case. Nicola, have you seen a significant amount of patients complaining of extreme fatigue and lack of stamina? Is it considered a symptom? I think it can be considered a symptom, yes. We don't know what fat accumulation in muscle chronically can do to the muscle. It could be also a central symptom, but I would consider it a part of the constellation of symptoms which are typical of the disease, yes. Is there some association with other autoimmune diseases? Yes, pretty much all of them in acquired lipodystrophy, especially in generalized acquired lipodystrophy. Pretty much every autoimmune disease, starting from type 1 diabetes, celiac disease, autoimmune liver disorders, lupus, sclerodermia, and so on. So we screen for as many autoantibodies we can in the presence of an acquired generalized form of lipodystrophy. Autoimmune thrombocytopenia, purpura. So any type of autoimmunity is at least in theory possible, and you will see that most of them were already reported in clusters with the disease. Well, I thank you very, very much for the questions. I think we're great. Unfortunately, I think I have to, there is one more, and then I think I have to pass the podium to Rebecca. One last question. I'm in Australia, and unfortunately, most of our medical profession has never heard of lipodystrophy. The patient is 54 years old. I would like to obtain some well-documented information to assist me in learning what blood tests I should ask doctors to do, and I should start leptin. I need this information also for my medical insurance. If you wish, you can easily find my contacts, and if I can be of any help, I will be very happy to correspond with you and give you all the information that you think are important and needed. I don't know much, honestly, about the treatment in Australia, but I'm sure that you can get access to the drug if you can benefit from it. Well, thank you again. Now is it's time for me to pass the podium to Rebecca Sanders. Rebecca is a PhD, is a representative, as I said, of Lipodystrophy UK, but also a patient representative inside the European Consortium of Lipodystrophy and our registry. Please, Rebecca.
Hello, thank you, Giovanni. My name is Rebecca Sanders, as you know, and I am the chair and founder of Lipodystrophy UK, which is a UK charity supporting people affected by lipodystrophy. As Giovanni also mentioned, I am the patient representative on the ECLIP board, which is the European Consortium of Lipodystrophies. Today I'm going to give you a brief introduction to the patient perspective of living with lipodystrophy. Patient support groups are really important and have a role in improving the well-being of patient populations. They are particularly relevant in the rare disease space, where generally there is less information available. People gain real benefits from shared experience, and sometimes when living with a rare disease, this can be quite hard to find. Patient support groups like Lipodystrophy UK are here to support patients and their families, provide information and services, raise awareness both within the general population and within the medical community, and can form fruitful collaborations with clinicians, researchers and pharma, which will benefit patient outcomes. Current lipodystrophy support groups include ourselves in the UK and groups in Spain, Germany, France, Italy and the US. We're always keen to hear about new groups and where possible support their development. So if you have a patient population without a local support group, I would encourage you to raise the idea with any suitable patients that you have. So I'm going to give you a brief overview of a couple of the projects that Lipodystrophy UK is currently working on. Some of you may be aware that in the UK we are currently seeking approval from NICE for the drug metreleptin, which Giovanni talked about, to be prescribed on the NHS. Metreleptin is currently the only drug available that directly treats lipodystrophy rather than just secondary symptoms such as diabetes. It's been quite a long process, which started back in 2017, and it's still ongoing. In May 2018, evidence to support the application was submitted by ourselves as patient expert representatives, the pharmaceutical company and medical experts. In June of that year, NICE held the first committee meeting to discuss these data and hear from patient experts and medical experts also. The patient voice in these decisions is really important, particularly for rare diseases, to give the committee a real life perspective of what the burden of disease is, which can sometimes be difficult to fathom. So the patient voice in these decisions is really important. The committee meeting was followed in July by the publication of their evaluation consultation document, the ECD, which summarised the submitted evidence. And in February 2019, a second committee meeting was held before the publication of the final evaluation document in June 2019. Unfortunately, at this time, NICE made the decision not to recommend metreleptin for NHS funding. So we immediately launched an appeal and in July last year submitted various appeal documents. In August, NICE officially cancelled the appeal in favour of a reconsideration step, and this gave us an opportunity to submit further evidence in support of metreleptin in May of this year. The committee meeting to discuss these data is scheduled for October, and a final decision should be made following this meeting. So we are hopeful that we will have a more positive decision following this meeting. We're also working on some body image projects. Lipodystrophy often comes with an altered physical appearance due to changes in fat distribution, which affect body confidence and mental health of those affected. And time and again, patients raise this as having a significant impact on their quality of life. Lipodystrophy UK has been working together with the UK Specialist Centre in Cambridge, Addenbrooke's Hospital, and another UK charity called Changing Faces to develop a body image workshop, which we aim to deliver to patients on an ongoing basis. In addition, we have joined the Appearance Collective, which is a group of organisations supporting people affected by changes in appearance, and is in association with the Centre of Appearance Research in the UK. And the aim of these projects is to improve the psychological impact of changing appearance and increase body confidence. At Lipodystrophy UK, we are really big advocates for allowing patients to lead the research, and I would really encourage you to listen to what your patient needs. A lot of important academic studies are performed, for example, to identify novel mutations. However, these types of studies do not always translate to a real-life impact for patients. So mutually beneficial to patients and the research community would be studies that aim to address concerns within the patient population, and that could potentially translate to better patient outcomes. In a recent study that we conducted to generate evidence for the most recent NICE submission, Lipodystrophy UK launched a survey to understand the burden of disease experienced by patients, and there are a lot of themes that came out of that discussion. Patients reported numerous symptoms beyond the metabolic impact that registered as having high impact on quality of life, and in particular there is a large interest for research into lipodystrophy associated fatigue. So I'm glad, I think Nicole raised that question with Giovanni. Fatigue is something that patients really suffer with and hasn't really been studied in detail. Also low carb diets and pain. Lipodystrophy UK would be keen to collaborate on such studies, and would have any studies that would have the potential impact on patient welfare, and we would encourage you to get in touch with any such ideas. Finally, just a quick note on patient pathways. As I'm sure you're aware, it's really important to have a consensus patient pathway to ensure that all patients receive the same level of care, regardless of location, from disease presentation through the patient's lifetime. Again, key to this is awareness, and following disease presentation, it's important that where appropriate, lipodystrophy is considered as a possible diagnosis in such patients. So awareness within the medical community of lipodystrophy is critical. Also an awareness of what treatment options are available, including unmet needs such as psychological support, and knowledge of various regional specialist centres for further information. If there's not a local specialist centre in your region, the knowledge of other specialist centres that you can contact is really important. And also ongoing monitoring of these patients is critical in order to progress track the progression of comorbidities. And this monitoring should continue throughout the patient's lifetime as the disease progresses. Anyway, I want to thank you for listening to a very brief introduction. This is me with a couple of my trustees, and I just want to encourage you to continue putting patients at the centre of everything you do. Thanks for listening. I'll have a look now and see if there are any questions, which is just saying thank you so much, and I appreciate your help from Trina. If there's anybody else that has any comments or questions, now is your chance. If you think of something later on, as Giovanni said, our contact details should be associated with the link for the webinar, so you can always get in touch in the future. As a patient organisation, you can contact us at lipodystrophyuk@hotmail.com. You can email anytime, get in touch, and we'll be able to get back to you. Also, we have a website which is currently under development, www.lipodystrophyuk.org, and we are present on various social media platforms, and I'd encourage you to engage with us on those platforms. Thank you very much.
To choose one study, what kind of study would you like to see performed? You refer to the fact that it's important to study fatigue, the mechanism of fatigue, or chronic pain.
I think fatigue at the moment seems to be the biggest issue within the community that hasn't been addressed. But as you say, there are a number of different areas, including pain, chronic pain that a lot of patients really suffer with, body image, and psychological impact of living with a rare disease. And also, as one of the main treatment aspects available to patients is diet therapy, looking at the impact of low-carb diets, which have been looked at more extensively in type 2 diabetes, but not with a link to lipodystrophy and the need for also having a low-fat diet. So those things are particularly important at the moment.
Yeah, you're right, because so far we do not have any type of specific guidelines for diet in the context of lipodystrophy. So we sort of follow general rules which sound proper, correct, adequate, but we don't know exactly what we should do in practice. And you are right saying also the physical appearance is a very important issue for our patients. We are now putting more effort than in the past to giving help under the fact that we can offer excellent plastic surgeries for patients who need them, and we have realized that this is definitely in some cases a priority for them, and
sometimes can be of real benefit to patients, although often because of the lack of subcutaneous fat, implants, for example, can shift in position and so don't always then generate the appearance that is desired. Also, in my experience speaking with patients, some patients with partial lipodystrophy may have liposuction to remove the excess fat that's distributed in inappropriate places, but often that will return in time. And so actually it isn't really a long-term solution for patients, and having a better understanding of the condition, how the diet will impact your appearance, but also an acceptance of your own body image and having confidence in your own body is actually the key, I think, rather than trying to change who we are. We are who we are, we look the way we look, and there's nothing wrong with that. It's difficult to deal with sometimes, and I think ways of being able to process that in a meaningful way that really benefits patients and improves their confidence will really help also with their management of their condition. You know, patients, we talk about diabetes burnout and patients getting fatigued with treatment. Well, you know, that's the same in lipodystrophy, particularly when it's a diet orientated approach, and with the lack of leptin, the severe hunger, the hyperphagia that comes with that can also mean that it's very difficult to control a diet. Low carb, low fat is very difficult to adhere to, but when you're hungry all the time, that's particularly difficult. So it's getting the right balance so that patients are confident to help themselves, but also so that there's a better understanding within the community of how best to help patients.
Thank you. Any other question?
Giovanna, no. At the moment, there are no other questions. Only a really nice comment of Nicola. Wow, so well said, Rebecca.
Thank you. But that's what's great about these forums, is that they see the importance of including the patient voice. And the patient voice is really important, because without it, there can be a disconnect between numbers and patients and actual real people. And we're fortunate that within the lipodystrophy community, ECLIP sees the importance of patient input, but also here at Endo-ERN, you know, including the patient voice again is seen as valuable. So we're thankful for that, and would encourage that to continue.
Absolutely. I would like to thank all of you for being with us today, for making so many questions, for being very active in the discussion. And I hope that we will have a follow-up maybe on specific sub-teams or things that we feel are important to be discussed and shared with you. For any reason, you can contact me. You can find easily my contacts, and I hope that we will repeat this experience very soon. Thank you all for being with us today. Thank you, Rebecca.
Thank you, Giovanni, and thank you, everyone.